Hey, good morning from beautiful downtown Sycamore Crossing in Blue Ridge, Georgia. Sorry we're a couple minutes late, so we're going to cut the front of the show. Had a little audio difficulty with Josh, our engineer over there. He fixed it, got it going, and so we're good to go. So we're going to jump right in. I'm your host, BKP, and we're going to jump right in with our segment, Ask the Doc. We always appreciate the Northside affiliated with Northside Hospital, North Georgia Cancer Research affiliated with Northside Hospital for this segment. Dr. Whaley, how are you?
I'm great, and let's get into it. The reason we're so slow this morning is it's cold in the mountains. 56 degrees up here, guys, and it's 110 in Paris.
Yes.
110 in Paris, okay. And it's, 98 or 6 or something there in Atlanta yesterday, and it's 56 in Blue Ridge, and that's why we're here. And you missed the train whistle. It's already been.
I got to enjoy last week the, they call it climate change events now. The 102 out of Philadelphia, which was 117 heat index. And I couldn't get my air conditioner to come on in the car. It finally did.
That's what they said in Paris. They said that the 10 hottest days in history in Paris have all been in the last 15 years. And it's climate change.
Well, I will say this. That's why I love my North Georgia mountains. I love cool mountain mornings.
Right. We haven't got any climate change
cool
in North Georgia.
Cool mountain mornings is like in the top 5 reasons. No joke. People say, why are you in the North Georgia mountains? Cool mountain mornings is in my top 5 for why I'm here.
Yeah, and fresh tomatoes for the big old tomato sandwich.
Well, I had 5. I told you within the top 5.
But right now my patients are bringing me these big old. I had a big old tomato yesterday, that big around, that was purple with bottling in it. I don't know what brand that is. And you get one slice about that big, 2 pieces of white bread. It's like wonderful. All right, here, first question. What are clinical trials and why do you recommend them? This question, I'm absolutely positive, came from 2 weeks ago when we were talking about what you do after stage 1 and stage 2 in treating cancer. And I said, always, if there's the option to take a clinical trial, do it. You remember me talking about the quiver?
Yes.
And the bow and arrow guy in the first the season? Well, all right, that keeps arrows in your quiver. Now, Josh, let's get that first picture up here. All right, what are clinical trials? People, this is probably the most important question that's been asked here in 2 or 3 years, because when people talk about Daddy has cancer and he's gone to the MD Anderson or he's gone to the Northside Cancer Center and they're talking about experimenting on him. That was the old word, experimenting on him, and that frightens people. The appropriate clinical trial is, if you look real carefully, clinical trials, and you're not going to read all this, but clinical trials aim to improve existing treatments or replace them with newer, better ones. You remember a few weeks ago I said, if you've got a clinical trial, it can't get through the institutional review board at Northside or MD Anderson or anywhere else, or through the FDA, unless your best information is that it is either more effective or less toxic than present therapy. You got that?
Mm-hmm.
All right, so let's get off of that first one and let's go to the second one. So there's so much talk. You see all these ads on TV about the new fancy drug that for this cancer, and my dad's, they $10,000, $14,000 a month or something, and everybody criticizes it. But here's how you're going to love this. This is how you get from the thing we were talking about. It's been a year ago, where the guy was in the Amazon taking all that mud and getting all of these organisms in there and seeing which one, if you put it in a petri dish, would inhibit the growth of cancer cells, where you get from that to a drug that you can take like Jimmy Carter did that makes you well. You ready?
Right.
Okay, show that first picture with the number of people on it. You got that one, Josh? It's got a bunch of people at the little spots in the middle, phase 1, phase 2, phase 3.
Yep.
All right, a phase 1 clinical trial is a patient who has exhausted all remedies, is given this compound that has been found to be effective in experimental first in petri dishes, second in mice, second in sheep, and so forth, and it's time to go into clinical trials, and it's somebody who has no other options. Literally, there are no other options. And that drug is then given to people with every kind of cancer that there is, and it's given in a low dose, several patients, then a little higher dose, then a little higher dose. And what you do is you then try to see, well, this particular drug was effective in this type of cancer, end stage, and the safe dose was this. And then you get some information on a small group of patients. That looks like it's probably 100 there in the world. They say, okay, this worked in breast cancer. So then you get into the phase 2 clinical trial. You see there's thousands of many patients there. This is where you hear randomized, and I'll show something about that in a minute, clinical trials that are blinded to the investigator. So you come in with a sore throat, make it easy, and you're going to get a pill, and that pill's either going to be the penicillin pill or it's going to be the new drug that we're testing against penicillin, and they make both of those pills look exactly the same. The doctor doesn't know which pill you got. The nurse doesn't know which pill you got. The patient doesn't know which pill you got. The only people who know what pill you got are way back here at the Research Institute and the National Institutes of Health, where they record your temperature every day and how quick did you get well. So if you get well 40% faster with the new pill than you did with the penicillin, with much less in the way of toxicity, that drug can then go into phase 3 clinical trials. See that phase 3?
Yeah, I mean.
Okay, that's big numbers.
Right.
That's where you've got all over the world. Now you're going to have Pima Indians here, and you're going to have Chinese over there, and you're going to have fat people over here, and you're going to have young ones over there, skinny ones over here, so that you then are getting huge data. All right, so we're going to pull that one off, and we're going to the next one. You got the next one there? All right, so after the phase 3 clinical trial, which this says here, tested on new and wider demographic. That was their way of saying short, fat Pima Indians and everything. That demography, that's what's the other word for that? Inclusive.
Okay.
Yeah, all right. So anyway, this test for long-term effects and comparison with other medications, and if that shows compelling, strong evidence, what's the next thing?
FDA approval.
All right, that's when that drug gets released into clinical medicine out there. Is the research over with?
No.
Absolutely not, because there's another block there in that phase 4. This phase 4 data is where once the drug's in clinical trial, then the manufacturer and the research group you get a lot more opportunity once you get it FDA approved to get it in use all over the world. Then they monitor the patients that get it for the first, let's say 500,000 or the first 2 or 3 years. Still monitor them just like they were under research to see if there's anything that sneaks in the back door that might be a side effect or might be added benefit, or that the amount of benefit you got, because statistics are so crazy, it diminishes. And one of the it just was announced a week or so ago, the FDA pulled approval for some drug for something I don't know anything about. It was some sort of pregnancy complication about a year and a half after it went on the market, because over the long haul the effectiveness wasn't the multiple they thought it was, and the expense was high, so they removed it, not because the drug didn't work, but because the cost was not worth it. Why spend $100 for a pill that's not any better than one that you're going to spend $1 for? So that's what phase 4 does. Okay, let's go to that last one here, because this is the part that people get confused about. when they say Dad's either going to get this treatment or that treatment, and we're not going to know which one he gets because some computer is going to decide, right?
Yeah.
All right. Well, that's what randomization is. Now, I'm old. I hate to say how old I am, but you remember when I've been involved in clinical research since 1968, and there weren't any computers, were there?
No.
No. You remember when we were talking a few weeks ago? You remember what an index card is? You probably don't. You know what a Rolodex is, all right? Well, you just imagine a box full of these little 4x7 cards, and the cards will be numbered 1 to 1,000, and you're going to go on this clinical trial, and you are number 276, and in essence, what you do is you just go run your finger down that thing, and you just pluck one out. And then that's going to say you're going to get this drug or another drug. So that was the way you did randomized clinical trials back in the days when I had, nice curly brown hair and no. All
right. Let's move this along a little bit.
All right, now.
You went to index cards. You got me thinking all kinds of things
so
right now.
So now it is done by computer. I hate to tell you. So it's called a random number generator, and it decides whether your mother is going to get R-CHOP or get the new trial. But whatever, if there's a new trial against R-CHOP, it's supposed to be better. All right, so that's the end of the thing on clinical trials.
Let me ask you one thing. Now, explain the difference or how it helped. Right to try. Put that into there a little bit, because I think what a lot of people, I don't want to say don't know, but I really think it is an amazing thing that has been done here in the last couple of years is you as the patient now have a right to try that you didn't before. Am I correct?
Correct. Now, you remember that phase 1 clinical trial?
Exactly.
Okay. That's the clinical trial where you do not have any clinical information in human beings that this drug will be effective. It is all experimental evidence that is in the preclinical trial area, where I said you got all kinds of cancers.
Right.
You give this drug to a small number of people at this dose. If the dose doesn't hurt them and nobody responds, then you go to the next dose and you give it to a small number of people. And if the drug doesn't hurt them and nobody responds, you go to the third dose. Well, you reach a point where you're going to have responses without toxicity, and then you're going to raise the dose, and you may get more responses with toxicity. You drop back to the dose that was effective in some patients without toxicity, and now you got to get numbers. Well, that's where the insurance companies will not reimburse anything. They won't reimburse a blood count, an office visit, or anything else. And you can't get into the clinical trial because your insurance company won't allow you to, and that's the right to try. So that somebody can say, I'm going down to Emory, or I'm going down to Northside, or I'm going to MD Anderson, and they have a phase 1 clinical trial that I might be eligible for, and my insurance company won't let me go. The right to try lets them go down there and do it. And I think that's a very important. This is America, you know. I mean, you're free to drive one of those blinking Range Rover Discoveries if you want to, and Consumer Reports says it's got bad longevity, but it's a really good-looking car, and it's got great sound system, so you can make your own judgment.
You can go buy what you want,
or you can get the Jeep, which
absolutely
they say got good
research.
Right. All right. So that's the right to buy what kind of car you want. You got the right to pick. You need to choose your doctor and choose what you want to take.
Because there's a lot of great research going on right now, especially with cancer. There's a lot of great research going on right now, and people are being healed or life prolonged or whatever.
They are, absolutely.
And it falls under it. So I didn't mean to sidetrack
that is exactly why we had this today. Anyway, that's how that question got here from those things a few weeks ago, because there was questions about experimenting on Daddy, and Daddy has the right to go get in that trial if he wants.
Right.
And there shouldn't be a barrier that Medicare or some insurance company gives to him. And that's the right to trial.
Well, I want to thank you for doing a really great job on breaking down, when you hear clinical studies, medical clinical studies, Dr. Whaley has done a great job of breaking down all the phases. We want to thank the North Georgia Cancer Research Center, affiliated with Northside Hospital, for this segment. And they bring us our second question. What do we have in our second one today, Dr.
Well,
Whaley?
I keep saying Dad, when I was making that today. My dad recently began cancer treatment. And I wondered, how do steroids and chemotherapy work? Now, this is actually another pretty good question. There's so much talk about steroid abuse, and you see the picture of the guy that's pumped up like this on steroids. That's testosterone. That's got nothing to do with the steroids that we're using in cancer therapy. Put up that first slide about steroids for treating cancer, because most of the steroids, and just show steroids for treating cancer, that's the label. Pull that one down and put the next one up. All right. Steroids for treating cancer aren't the testosterone. They are the cortisone family of drugs. It's what, the cortisone you rub on your poison ivy, and
Right.
and that they give you for the asthma and the cough and the wheezing. So if you just look at the basic uses, just show that one about uses, Josh. So corticosteroids are basically used for a bunch of things. Here, to start off, reduce inflammation. That's the asthma and all the rest of that stuff. Suppress immune response, rheumatoid arthritis, lupus, autoimmune diseases. Now, in cancer, most of the time when we use a steroid, it's either to prevent or to treat nausea, vomiting, and the old chemotherapeutic side effects, and get rid of them. So still has nothing so that's cancer treatment, but it's purely to make the cancer treatment easier on you. And actually, they're also given in the terminal phases of hospice to reduce pain and increase appetite. Now go to the next one, because I think what the real question is not what do you do with steroids to increase appetite or to diminish nausea. Now we're just going to show this briefly, because it starts talking about being an NK inhibitor, an apripitatant, and a serotonin antagonist, and you can pull that one off. But technically, steroids, this next one I think is probably the most elusive one. Steroids affect virtually everything metabolically that happens within the body. And this, in terms of cancer treatment, if you just take a look at the left-hand side over here, where steroids are used, lymphoma and leukemia, and you have knowledge of people who are taking steroids, CHOP-R, the P is prednisone, which is a steroid.
Right.
All right. That's lymphoma. Breast cancer patients, prostate cancer patients, leukemia patients, ovarian cancer patients, all these different kinds of cancers, and multiple myeloma, all of these different kinds of cancers are giving big doses of steroids, short period of time, either 1 day, 3 days, or 5 days out of a month. And that's totally different than this low dose that they give, like for poison ivy or to reduce nausea. And in that situation, the cortisone, now go to that next picture. And I'm not going to try and get you to figure out all this, the targeting, but this picture here it is a little bit about the chemistry of it. It will affect different parts of the cell cycle in different cancers. So you can't just say cortisone blocks mitosis or cortisone increases tumor killer cell recognition of it does all sorts of stuff. So you can pull that off and get those things off the screen. But basically, steroids, not the weightlifter steroids, cortisone-like drugs, and the common one in cancer called prednisone, does so many things that I would say just about every patient that is treated for cancer, whether it's radiation therapy for a skin cancer all the way through to a bone marrow transplant, will receive a corticosteroid, prednisone-like drug during their treatment? So it was a real good question. It's just that its spectrum is so far from low doses just to prevent nausea or to increase appetite here to huge doses up here that actually kill leukemia cells and lymphoma cells.
I think what happens is, through just, let's say, athletics, we hear steroids and it has such a sweeping brush.
Yeah, right.
Right. It's such a wide paintbrush
right,
when you just hear steroids. Well, they're giving dad steroids. They're giving mom steroids. Well, okay. Will they, be able to hit a home run here soon? I mean, I know it's, but you understand.
Or Lyle Alzado died of cancer caused by taking too many steroids.
Right. Exactly. So I think that wide brush, that when you hear steroids, some of us miss out that there is really good medical benefits to treatments that steroids are used for.
Yeah.
Did I get that right?
Absolutely, yeah. And actually, I hate to say it, but the testosterone-like drug, which is the one that gets the bad paintbrush, we also use in relatively low dose to stimulate appetite in people who have had big surgery or big chemo. And many of our treatments place women into menopause and put men into testicular failure. So we frequently are using a lower dose of testosterone. So actually, even though that's the one that's painted badly in the public eye, it has a place in cancer treatment.
Well, now before we go on here, our audience will not understand this, so don't take this. I'm sorry, but I've been wondering how you got that parking space. But we'll talk about that later. I've been wondering, how'd you get that parking space? I don't, I thought that parking space had somebody's name on it, but we'll just go there.
That parking space comes from the 4th of July parade,
does.
and it's bait for these stores.
I got it.
People come here and they get their picture taken, and it gets men here, and then the women can go in the stores and spend money.
Listen, let me just say, seriously, all jokes aside, we are at Sycamore Crossing at downtown Blue Ridge, Georgia. Beautiful morning, absolutely beautiful. But there is a beautiful Chevy truck. What year is it?
65.
There's a beautiful 1965 red, oh my God, truck sitting out in front of Sycamore Crossing. That if you visit Blue Ridge, you come down Sycamore Crossing, check out the truck. Like
Get your picture taken.
Get your picture, because it is one you want to do. Okay, I've been wanting to wonder how you got that parking space. Okay, Dr. Whaley, at this time, you always share with us something that is new and going on in the medical field out there.
All right, I got one quick admonition that's going to be on the radio or on the TV today. And in this community here, there are a number of well-known people who have gone to Mexico for the purposes of having an obesity surgical procedure that's called the gastric sleeve or the gastric band or gastrointestinal bypass. And they have had fine results from it. Once before, we have talked about what we call medical tourism. There's an epidemic of fatal post-operative infections in the gastric band and gastric sleeve surgery from that institution in Mexico right now that have killed about a dozen people. And it's a caution that medical tourism, you really need to be very, very stringent in investigating the place that you go. There's great dental clinics in South America where the people were trained here, and they're a lot cheaper than the $2,000 crown I got here, facelifts in Brazil and other cosmetic surgeries. But the gastric surgery is not a tummy tuck. And right this minute, there's a significant post-operative problem going on down there. So we'll get from that to regular news. You ready?
Yes.
All right. I really love this one because you probably saw something about it that a couple of days ago, 3 bedroom communities of Atlanta, Smyrna and Covington, were found to have a chemical in the air called ethylene oxide. Did you see that?
Yeah, okay.
It's a cancer-causing chemical that is coming from a medical sterilization company called Steroids, which you've never heard of, which was Bard and Bard Parker, huge company. Sterigenics has 3 plants, 2 in Smyrna and 1 in Covington. They got 1 in Illinois somewhere where the concentration of this stuff is fairly high. And the article was written that their cancer chemical is in the air in Smyrna and in the air in Covington, and this company is guilty of it. Well, it's true. The chemical's in the air. The company is guilty of it. But as the EPD person from the state of Georgia and the EPD person from the federal government said, this article is written as an inflammatory attempt to make people mad and to make people angry. And it was written in such a fashion as to just shock. This concentration of this stuff is minimally higher than permissible, which it shouldn't be, and the companies are mitigating that with new technology. But they made it like if you go outside, you're going to be mustard gassed like in World War I. Now, it put me back in, because I am so old, back into the big scare on radon. You're probably too young to remember radon.
Radon detectors.
Our other expert panels over here, everybody was worried about radon. And they were suing builders for building a house that had high radon in the basement. Well, if you
when I built houses, this is years ago. When I built houses, we had to do radon testing. The homeowners had to be a part of the report when we for the basements, radon testing.
All
Absolutely.
right, now
got it.
I was born and raised in Buckhead. There is a bump of land not too far from Atlanta that's famous around the world called Stone Mountain.
Yes.
It's granite. And therefore, the underpinnings of the city of Atlanta are granite. When they built MARTA, they had to go through granite. Well, what's the highest radon producing natural substance other than the coal mines out in Montana is granite. So every big home in Buckhead has got real high radon in the basement because they're all built close to that granite.
Right.
Okay, they were all built back by famous architects before you could sue or you had to have a radon thing, but it just scared people to death. How many people do you know got radon-related cancer in Buckhead or anywhere else from the radon? So this is exactly, in my opinion, I hate to say fake news, but it's the news media's way. Who's going to read an article that says there's a chemical in the atmosphere that's 1.6 times the naturally occurring permissible, and it ain't going to do anything to you, and somebody's going to have to fix it? Well, nobody's going to read it.
You got to energize that article. You got
to jazz up the article.
Yes, sir.
You got to jazz up the article. Okay, so that's what they did. All right, now the second jazz up that has occurred this week is the textured silicone breast implant. Remember that one? I know you've been traveling. Okay.
No, let me hear this.
All right. Well,
try to stay clear away from breast implants.
Allergan.
Sorry, I don't know where that went.
Allergan is a huge company. I think they started out making eye drops and something else.
Okay.
Well, Allergan owns the silicone breast implant that about 20% of the breast implants in the United States, and more than that in Europe, are Allergan silicone breast implants. Now, if you've ever seen one in a photograph or something, they're slick and they look like a bubble or a bubble of water, or a bubble of plastic or something, or even like a jellyfish. Well, and then they tended to have a capsule that was kind of hard, so Allergan began to make them with a textured surface, so the surface was ribbed a little bit, and there were all these surgical reasons why the ribbed breast implants were better. Now, you can't get it, but they would stay more mobile, more uniform in shape and everything. Well, we know that when you put a foreign body in somebody, it's going to stimulate immunity in some fashion, and that's why it gets capsule formation. Well, there have been about 481 about, how's that? That's pretty much about, cases of lymphoma occurring in recipients of the Allergan breast implant worldwide in the last 4 years. Now that sounds like a huge number, except that there are a couple million people out there with that implant. And now the headline was, Allergan recalls this textured breast implant. Well, that sounds like you got to go to the doctor and get your implants taken out and get new ones put in. How do you recall a breast implant? What that meant was they got to take it off the shelves and not sell any more of them. The bottom line recommendation is not to go take the darn thing out, but do what you're supposed to be doing anyway, which is an annual mammography, getting your breast checked. And every woman that I've ever seen that's had a breast implant from the age of 14 to the age of 90-something, I've explained to them, you will never be able to check your breast. The doctor will never be able to check your breast with the degree of accuracy after that implant that he could without an implant, and therefore you must get a diagnostic mammogram at a place that knows what they're doing. And that is what the bottom line of this recall of the breast implant was. But it was on the news and in the daggone high up in the front page of the newspaper here in the last week. And again, I think that's the press making this huge flap up here about something that's real, but it's real at that level. There you go. So ethylene in the air, breast implants, and that's fake news. And that's my way of getting to the fake news and my criticism of the regular press. How's that?
Well, I want to tell you personally how much I appreciate you. One of my concerns in life, here's one of my concerns in life now, that I'm in a room somewhere and somebody has something happen medically, and somebody yells, is there a doctor in the room? And there's no doctor in the room, and I have to say, hey, I know a doctor and I've took his class for 3 years, but that's my concern.
I played one on TV.
Yeah, I've taken Dr. Whaley's class for 3 years, so that's a concern. So anyhow, folks, listen, this is great information every week with Ask the Doc. Go to our YouTube channel, FYN Train Whistle, FYNTV Fetch Your News. Go to our YouTube channel, subscribe. Also, look at the playlist, Ask the Doc playlist. Share these with your friends. If you've heard some information today, you say, wow, I'd really like family members or friends to hear that. You can go share that today. We put it on our YouTube channel. Also, if you have a question for Ask the Doc, just send us an email at info@fetchyournews.com and say in the subject line, Ask the Doc, send us a question for Dr. Whaley. Again, we want to thank North Georgia Cancer Research Center, affiliated with Northside Hospital. Thank you very much. I appreciate it. I like that tie. I like it. Goes real well. I tell you
Century
what,
21, the discount place in Manhattan.
There you go. There you go. Going to work looking sharp. Thank you very much, Dr. Whaley. We will be right back with the All-Star panel. And I'm always concerned if we have anything to talk about. But I know Jane, Rick, and Bruce are ready to go after these messages.